I'm Ramaswamy Govindan, a medical oncologist at Washington University School of Medicine. We'll go ahead and introduce other panelists here. Dr. Lanuti.
Yes, hi, Michael Lanuti. I'm a thoracic surgeon at the Massachusetts General Hospital in Boston and the director of thoracic oncology for our division.
My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis.
I'm Sanjeev Bala. I'm the head of cardiothoracic imaging here at WashU in St. Louis.
I'm Dr. Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine.
A 61-year-old man with multi-month history of hoarseness with a mass in the anterior mediastinum. The biopsy is consistent with poorly differentiated thymic carcinoma. There is no evidence of metastatic disease, we are told, on the PET-CT scan. And we are going to be discussing the preferred management for this patient. So I'll just go through the history very quickly. This patient presented with multiple months of hoarseness of the voice with very typical symptoms we see, some fatigue, 15-pound weight loss, and has some performance status of 1. The past medical history is significant for stroke with no residual effects, intermediate risk prostate cancer, epilepsy on carbamazepine, well controlled, and the social history is a former smoker, quit 3 years ago with no significant substance abuse history, and family history is remarkable for prostate cancer and pancreatic cancer. So, Dr. Bala, do you want to review this CT scan for us?
The CT scan shows that there's a heterogeneous mass that's sitting in the anterior mediastinum, extending into the AP window. It measures about 7 by 7.5 centimeters, and there is some concern that it involves the great vessels. And we have a follow-up PET-CT, which shows that there is uptake, and it's mostly along the periphery with relative central sparing, with increased uptake of FDG on the PET-CT, with a max of a 2.1.
Great, thanks very much. So this patient underwent a biopsy of the mediastinal mass. The mass is consistent with poorly differentiated carcinoma, with markers positive for cytokeratin 7, 10, and 5, and negative for other markers. And this was read out as primary thymic carcinoma. And seen by medical oncology, radiation oncology, and surgery. And now we'll start off with Dr. Lanuti. This is where we start our tumor board discussion about the issue of operability. And after you comment on this, I like to have Dr. Bala come back and talk to us about what he typically looks for in guiding physicians when you review a patient with anterior mediastinal mass and thymic thymoma in particular. Dr. Lanuti?
Yes, thanks. So regarding, well, we have a diagnosis already. Oftentimes we don't, but let's move ahead and say we have the diagnosis. Thymic carcinoma, as we all know, is more locally aggressive, and albeit that does happen, surgeons should still consider resection if it's possible. So that is, in thymic neoplasms, really it's the best outcome variable that we use is a complete resection. Now this looks somewhat opposed, that this is locally aggressive into great vessels. You really can't tell perfectly by CT. Sometimes we get MRI and sometimes dynamic MRI to see if it's into vessels. Pericardium doesn't really bother us. But when we're thinking about looking at patients that are eligible for resection, we look for, of course, fitness status. Can they tolerate a major operation? This is not a minimally invasive case. This is going to be a maximally invasive case. And when we see things like this that are locally aggressive, we want some help from our tumor board. And oftentimes, I'm sure we'll comment about whether we give induction chemotherapy or chemoradiotherapy. We often want that help to see if we can get even better probability of a complete resection.
That's great. Dr. Bala, do you want to comment on any of the radiological aspects when you evaluate patients like this?
Yes, well, I'll say that it's very difficult to tell from a CT if you're dealing with a thymoma or a thymic carcinoma. But looking at the attenuation of the tumor on a CT can be very, very helpful. The more heterogeneous it is, the more likely it is to be a thymic carcinoma as compared to thymoma. But you have to be careful that it doesn't have fat, because fat would be more typical of a teratoma or some sort of germ cell tumor. And I really appreciate what Dr. Lanuti was saying about MR, because if there's a question about invasion of adjacent mediastinal structures, MR, especially with real-time imaging and with breathing, can be very helpful for differentiating whether there's involvement of adjacent structures. So I think imaging can be helpful, but it's not completely diagnostic.
Are there any concerns about doing a CT-guided biopsy for the fear of rupturing the capsule?
The biggest fear is if you're dealing with a germ cell tumor, because you fear that you'll end up releasing sebum into the mediastinum and causing a chemical mediastinitis. But for a thymoma or a thymic carcinoma, an anterior mediastinal biopsy would be very appropriate.
Dr. Lanuti, do you have any concerns?
Yeah, so we've this is always brought up in tumor boards, and I think that fine needle aspiration biopsies, there's never really been a problem. It comes down to core biopsy. So the core biopsies, have they been associated with local recurrence? To my knowledge, there isn't really any studies that really support a local recurrence along a needle tract with FNAs, and then with core biopsies, which we often do for this, we have not seen it, at least in our own experience of over 3,000 patients.
So would you operate on this patient right away?
I would not. So because this is going to be hard to resect, and I'm going to be leaving likely positive margins, I need to know what we're dealing with. Getting histology helps us all, and sometimes we can direct therapy better.
Okay. Dr. Robinson, your comments.
Yeah, I'll echo what's been said so far. I think one of the important points, though, is that in the spectrum of thymic neoplasms, there definitely is a different pattern of failure and recurrence tendency for thymic carcinomas compared to thymomas, which I think more closely parallels non-small cell lung cancer. So in our experience, we would typically think of managing these as if it was a locally advanced non-small cell with local invasion, so a T3 or T4 and M0, and I think those same principles apply then. So the notion of either induction or adjuvant therapy, trimodality therapy when possible, and chemoradiation when it's absolutely unresectable.
Dr. Levy, maybe we'll have your thoughts on the systemic therapy in this setting before we wrap up this management of this actual patient. So how would you approach this patient?
I think that there are competing standards. I think that Dr. Lanuti, leaning on the surgeon first to say, is this surgically resectable? And if it's not, I think if it's potentially resectable, you obviously have two choices with induction chemo or induction chemoradiation. I don't think we have any good phase 3 studies comparing those two strategies. At our institution, we would be most likely to be proceeding with induction chemotherapy. I think the question is then, what chemotherapy do you give? And again, we would present this in tumor board, and the radiation oncologist could also weigh in on their thoughts on whether radiation be into the induction regimen. But if we went with chemotherapy alone, I think there are two competing strategies for chemotherapy. There's CAP-based regimens, which is cisplatin, adriamycin, cyclophosphamide, and then carboplatin paclitaxel has also shown potentially preferential activity in thymic carcinomas. Both of those would be two reasonable strategies as induction chemotherapy in this case. This patient is 61. We have more data with CAP than we do with carbotaxel, but there are institutions, I think, that use carbotaxel for thymic carcinomas. I think we more default to where the wealth of the data is with CAP-based regimens. Keep in mind, induction chemotherapy alone can elicit responses anywhere from 50 to 70% in the potentially resectable space. That's high. Small numbers of patients when we're reporting these numbers. But nevertheless, I think that this patient warrants, at the very least, chemotherapy with either CAP-based regimen or carboplatin paclitaxel.
Dr. Levy, perhaps because of my age, I am less optimistic when it comes to thymic carcinoma. And thymoma, I grant you that they respond pretty well to chemotherapy alone. I see thymic carcinomas, most of them behave more like locally advanced squamous cell carcinoma of the lung. And I just want to know whether you have any comments on that.
Yeah, I think, as mentioned by Dr. Robinson and others, I think we view thymic carcinoma through the prism more of a locally advanced non-small cell lung cancer. I think this is where you get everyone in the room to make a decision on what's the best induction regimen. We don't have phase 3 trials with this type of tumor histology comparing induction chemo versus induction chemoradiation. Certainly, I would be receptive to induction chemoradiation in the event that we all thought that this was the best way to proceed with the potential to resect later. I can tell you, however, at our institution that we've had several young, fit patients in their 50s, early 60s, where we have just offered induction chemotherapy for these patients, followed by surgical resection, reserving radiation on the back end post-surgery if needed.
So, one of the problems we have in thymic neoplasm literature is that the thymoma and thymic carcinoma are lumped together. While you can see that as a continuum in some situations, they are very different diseases, right? There's more autoimmune disease with thymoma, much more benign. Thymic carcinomas are more aggressive. So my own approach is, maybe in the interest of time, I'll stick my neck out and say this, and then others can weigh in very quickly before we move on to the next patient. My own approach has been to go with chemoradiation, assuming our radiation colleagues would be supportive in that particular patient, and then consider surgery. And I don't recall very many patients going for surgery with thymic carcinomas. I'd like to get very quickly each one of your thoughts. How would you approach, assuming there's no distant disease and your dynamic MRI shows no other concerns and you can operate on these patients? Let's start with Dr. Lanuti, then Dr. Robinson, and Dr. Levy. Dr. Lanuti.
So we wouldn't be adverse to that chemo-RT. I think we've participated in a clinical trial looking at the induction chemo-RT. Really, it didn't, and there weren't a lot of thymic carcinomas, granted, Dr. Covinden, so a lot of them were this locally aggressive thymomas. So I would say that what does chemo-RT do to the surgeon? Well, it does make it a little harder to resect. The field is a little bit more hostile. Can it be done technically? Yes. Do you get a better R0 resection, at least in those small studies? The R0s were 70, 80%. With the caveat that you had a little bit more toxicity.
Yeah. Dr. Robinson.
Yeah, I think this goes to the kind of age-old concern of the value of these induction regimens as whether they actually truly increase resectability or whether they instead get the upfront sterilization of the margins done earlier, and then potentially for patients that cannot go to surgery, then you've actually delivered a definitive therapy. I think that's generally been one of the value propositions that we propose, is that if you do it up front and for whatever reason they do not go to surgery, then you've now at least given them a definitive treatment. But to the extent that we want to make sure that we don't create hostile operative environments for the the local tissues, if that there's going to be a high likelihood of resection, I can definitely see the value of waiting for radiation for later. I think it's a very difficult to answer question, and if we haven't figured it out for locally advanced non-small cell, I think we certainly haven't figured it out for thymic carcinoma.
So true. And I would say, in a way, by way of closing this discussion, that it is important to appreciate that about 10% of, maybe it's a little optimistic, but 6 to 10% of patients with thymic carcinoma have somatic mutations in the tumor cells of c-KIT. That's an imatinib-sensitive mutation responsive to these agents. So it's worth looking for that. That's, however, not seen in thymoma. The second point is that the checkpoint blockade, that is immune checkpoint blockades, have shown some activity in thymic neoplasms in the range of up to about 20%, and some of those responses are very durable. But then the immune-related events, particularly the myositis, myocarditis, are more common in this group than any other group. And there is some hint in a study with avelumab that presence of acetylcholine receptor antibody may identify this group of patients who have high risk for myositis. I just want to say that, and there are a couple of key points. So in summary, if it's localized after a good evaluation and dynamic MRI surgery versus chemoradiation or chemotherapy followed by surgery, is not unreasonable.